Hello and welcome to CardioTube. We're here at CRT 2024. I'm Jaffar Khan, interventional cardiologist at St. Francis. I have my good friend and colleague Yair Feld over from Haifa with us, interventional cardiologist and also a mastermind behind several devices. Today we're going to be talking about the splitter device. So Yair, welcome. So why don't we start by just explaining a little bit about what the clinical need is, and then we can jump into details of the device.
Sure.
Yeah.
So the problems that we are facing today, and it seems to be emerging, is mostly TAV in TAV.
Yeah.
That we are expecting a huge increase.
Yeah.
Because we are now putting these valves in a younger and younger population, and almost half of the patients below the age of 65 are receiving TAVI valve.
Yeah.
We are expecting within a few years to have many patients that will have valve degeneration and will require a TAV in TAV. And there we don't have a good solution in case of coronary obstruction. Usually the valve sits higher than the native leaflets, and once we push the leaflets of the previous valve to the side, we have a risk of coronary obstruction or sinus sequestration.
Yeah. So the concept that we have at the minute is just a single slice down the middle, right? The basilica, but it may have some limitations in TAV and TAV.
Sure. So we have few problems with TAV in TAV.
Yeah.
First of all, we don't have commissurable alignment in many of the cases, which is pose a problem. And we think we will probably need not only to have a cut, but to take a piece of the leaflets in order to really reduce the risk of coronary obstruction. If you make a cut, you may still have coronary obstruction, and you may also have problem of coronary access. So even if you did not cause coronary obstruction, if that patient have coronary artery disease and you will need to go back to his coronary, you may have a serious problem.
Yeah. So I think it makes sense, to with a split gives you a little opening sometimes. If you can create a wider opening, you can correct for any commissure misalignment and ease of coronary reaccess. So tell us about the splitter device then.
So the splitter device is it has two jaws, and inside the jaws we have a running loop that is connected to electrical power from the back. So this way we use the advantages of the basilica of having an electrical cut, but we are also taking a piece of the leaflets and not just making a cut. So we are combining those advantages.
How big a piece do you take roughly?
So it's about 3 millimeters over, depending on how deep you want to go, but you can go as deep as 10 or 12 millimeters.
Yeah. And in terms of the width?
3 millimeters.
3 millimeters width, and then the depth about 10 millimeters. So that's pretty sizable, right? And so you expect that once it's pushed out, the splay would be significantly greater than that chunk.
Exactly.
What? How can you confirm that you've actually got leaflet cut?
So that's a great question. So once you take the device out, you should have a piece of the tissue that you have taken that you actually cut. So it's a horseshoe cut. You take it.
Okay.
So you have, unless it's embolized, but we are not expecting embolization of that.
So that's interesting, right? So the two things that we think about in the community a little bit when we think about excision is, one, will that excised piece embolize? So what are the guardrails, what's the safety features to prevent embolization? And then the second is severe AI. After just a split, we get, I guess the thought is if you take out more leaflet, you get more AI. So just briefly on those two topics.
Sure. So I think this, in terms of, I will start with the regurgitation. So if we look at the balloon-assisted basilica, it seems to be working pretty well. And I think we will not cause larger splays than balloon-assisted basilica. And so I don't think we have a great risk on that aspect. And also, we have a wire already in the same wires that we use for the TAVI procedure will be in the LV. So once you do your cut, you take the device out and you bring your valve in. So it can be like 2 to 3 minutes before you start the deployment of the valve. So I don't think it's going to be like it's not going to be long. So both aspects, I think, cover this issue pretty well.
Yeah.
Still, it may be you may need to do an emergent implantation in some cases, but hopefully this will be rare.
And the embolization is?
Now, regarding the embolization, so we have a few needles, in the grasper,
Yeah.
that holds it well. So once you make the cut, it holds well in the device, and it should not embolize. And of course, we have to test it and show it in animals that we can catch it and that it's not embolizing.
Can you cut multiple leaflets? If you need both left and right cusps, you can cut both.
You will need two devices.
Two devices.
You will need two devices, and it's a question whether you will want. So I don't know. So with basilica, for example, if I had to do both leaflets, I make them have them both ready, and then cut one, cut two, and go quickly because the risk of regurgitation becomes much higher if you make two cuts. So this is how I do it. So probably need two devices, have two devices ready with two access sides.
Yeah.
Cut, and come with the device.
Where are we with the development stage? Like, where are you?
So we are expecting to start the first in men study within 12 to 18 months.
Okay.
Yeah.
Yeah, that's rapid progress. Yeah. Great. So in terms of, you're going to start that in Israel?
Well, the first in men, we probably have centers in Israel as well, but usually we also have other centers as well. For sure, we will start with centers that are high volume TAVI operators, because those centers that will have patients that coming with need for valve in valve, you cannot do it in like third world countries. You will not have that type of patient. Right? So probably both.
Yeah. And in terms of when do you think we can get hold of the device in trials in the US? What do you think the timeline for that would be?
So I'm not sure yet.
Yeah?
We have not decided.
Sure?
Yeah, we have not decided which centers where to go first. Strategically, it's a question of funding as well as there are other issues. So it's probably be Europe or USA for the first in men, and maybe we will combine depending on the funding and the availability. So yeah,
great. Well, I think I've covered everything that I wanted to ask. I think it's very exciting. I think I agree the need for TAV and TAV and the need for slightly greater space is pretty self-evident to those of us who do leaflet modification therapies. And you've shown me animations and pictures of the device, so I'm excited for the progress. Congratulations. I know you're presenting later today at the innovation session as well. So good luck with that.
Thank you so much.
All right. So thank you very much, and we'll see you later.